Good evening, everyone. It's 31st of July 2025, Thursday, 5 a.m. So, good morning. I didn't sleep the whole night because I had slept the whole day yesterday. It's like I'm back to my nocturnal habit, which is not very good, but as I was not feeling well for a week, it just can't be reversed. So, I'm trying to be, again defeat my this habit pattern, and which I will. So let's start with the Hess chart. Let's start with our strabismus series, and I'm going to start with the Hess chart. I literally gave it 3 hours. I watched so many videos with 2x double speed, and then I read Pradeep Sharma. Yeah, I think that's enough. For Pradeep Sharma is enough. It's there in Albert Jacobi also. I didn't read Jacobi, but because I feel this is enough. So Hess chart. Now when you're talking about Hess chart, when there is a short note on Hess chart, usually such practical things should not be asked in theory exam. But honestly, in our postgraduate college, Hess chart testing was not available. That electronic system was not available, so I have never done it myself. So I watched so many videos, and I'm going to share links of these videos. You can see them in the description box. They're really nice. 3-4 links I'll just share there. Definitely go through them because these are just notes, so you shouldn't miss any point. But for a better understanding, because when you see how it is, how the test is done, how the chart looks, then it's good for you. So first you go through these videos and then come back to me. At least 2 videos you go through, and then you come back to me here for the rapid revision. So Hess chart, when you are describing anything, especially this Hess chart, you just describe about its history, scientists who discovered it, then how it used to be in the history time, previous time, and then principle of it, requirements, limitations, uses of it, limitations, then how the Hess chart is, what are the testing points, and what is the frame of it, then procedure and interpretation. So let's start with the history of the Hess chart. I'll share the screenshots in the post part of the YouTube channel. I'll take the screenshots, I'll share it in the video also, and if the video is being longer, or you can just go through the post part, we'll see. I'll try to share it after this video. So history, scientist, the scientist who discovered this, actually it is, this Hess chart is named after one, I think he was a neurologist. Yeah, so his name is Walter Rudolph. I don't know the nationality of him. You can Google it. Walter Rudolph Hess in 1908. He discovered what? He discovered this system to assess the eye movement and to diagnose the extraocular muscle palsy. But that time it was not electronic screen or laser lights. He used what? The prototype of it. He used what? He used the threads, the green thread and the red thread, and the green thread was to be superimposed on the red thread at the testing points. So what's the principle of the Hess chart? Principle that was in the old days, and nowadays there is an electronic screen, then there are testing points are there, and on those testing points the red light is projected, and the patient is given the torch which throws the green light, and patient is asked to superimpose that green light over the red light that is projected on the screen. So accordingly what happens, either it is a handwritten map by the examiner, and nowadays it's like a computerized, there is a software program and a computer screen that will give you the mapping. You don't need to do it, you don't need to go for manual mapping. One can go for, you know, one can get the print. Like, this is what I think, I have not seen, but this is like, there is a software and computer gives you that mapping after the tasting points. So this is this Hess chart was the prototype, that is the thread pattern in the past days, and now electronic screen, and now even advanced is the software computer screen. You don't need to, you know, manually map the, or give the manual map of after the taste. It's the computer itself, it will give you the mapping of those tasting points. So what is the principle of Hess chart? It's the haploscopic principle. Now what is, there are tastes, strabismic tastes, which are based on the diploscopic principles that we'll see later on, because I have to recollect and, you know, go through all the examinations, go through all the principles and combine them, and at the end of the examination of squint part I'll be talking about the tastes based on the diploscopic principles, so I shouldn't miss anyone, and the tastes which are based on the haploscopic principle. So what is haploscopic principle? Haploscopic principle, this Hess chart is based on the haploscopic principle. Haploscopic principle means what? There are two objects in the visual field. There are two separate objects in the visual field, and they are projected on the fovea. Okay, this object is projected on this eye and fovea of this eye, and this object's image is projected on this eye. So these fovea are projected with these two different images, and then it is seen as a single image. So that is called as haploscopic principle. Haploscopic principle means two separate objects in the visual field, when projected on the fovea of the 2 points, they are seen as a single object. Two objects seen as a single object in the visual field by the two eyes using the cortical fusion mechanism, that is called as haploscopic principle. You just remember, there are two separate objects in the visual field, and patient is having central fixation, no anomalous retinal correspondence, no suppression, and fusion ability intact. So in this case what will happen, like foveal fusion ability intact, so two objects will be seen as one object, that is haploscopic principle. And diploscopic principle is what? There is one object in the visual field, but the two eyes together will see act as two separate objects. There is one object, one finger, but it will be seen as two fingers. When it will happen? When there is misalignment of both the eyes. So what happens? This image falls on fovea of one eye and extrafoveal point on the other eye, and when there is no fusion, what will happen? Then what will happen? There is diplopia, double vision. So that is diploscopic principle. So haploscopic means two objects in the visual field seen as one object, that is haploscopic principle. And diploscopic principle means the one object in the visual field seen as two objects because of the ocular misalignment. So this Hess chart is based on the haploscopic principle. Now what are the prerequisites when we want to do the Hess charting? What the person should possess? The person first should be cooperative in senses. You cannot do the tasting on the child who is not cooperative. The patient is having psychiatric illness, or the person is very old and irritated, or any irritated patient, uncooperative patient, you cannot do this test first. Second thing, both the eyes should have central fixation, no anomalous retinal correspondence. Central fixation, no harmonious or anomalous retinal correspondence, central fixation. Then no suppression, and there should be good vision in both the eyes, no poor vision, and color vision, no color vision blindness for red and green colors. and the patient should be given full refractive correction at near end distance, because this it is carried out at 50 centimeter distance to 1 meter distance. 50 centimeter is given in this Pradeep Sharma. So these are the prerequisites. What are these? Central fixation, no anomalous retinal correspondence, no suppression, good vision both eyes, no red-green color blindness, full refractive correction, and cooperative patient. Now what are the limitations? Obviously these points only you just reverse. Patient, it cannot be done in uncooperative psychiatric patients and children who are uncooperative. And if there is anomalous retinal correspondence, we cannot do it. Suppression, cannot do it. Red-green color blindness, we cannot do it. And if there is a suppression, we cannot do it. Anomalous retinal correspondence, cannot do it. Poor vision, we cannot do it. So these are the limitations of this test. And what are the uses of this test? Uses of this test, it has the diagnostic, prognostic value. So diagnosis of the paralytic squint, whether type of the squint, paralytic squint, whether committant, whether incommittant, whether hypertropia, or horizontal or vertical tropias, that is paralytical, committant or incommittant. Then second, restrictive, whether it's paralytic or restrictive. Yeah, so these are the diagnostic uses. Then yeah, and if it is a paralytic squint, the chart will obey the chart will obey what? It will obey Hering's law of equal innervation and Sherrington's law of reciprocal inhibition. So Hering's law of equal innervation means what? If we want to see on the right side, the right lateral rectus and left medial rectus, these are the synergistic muscles, contralateral synergist. So these two muscles will receive the equal innervation, equal stimulation to carry out the smooth movement at the same time. So that is the Hering's law of equal innervation. And Sherrington's law of reciprocal inhibition means if you want to see on the right side, the right lateral rectus will receive the stimulatory impulse or stimulation. At the same time, the medial rectus of the same eye will receive the equal inhibitory signal. That is the ipsilateral antagonist. So that is the reciprocal, Sherrington's law of reciprocal innervation. Now that was about the uses of it. Now progression of the disease. To see whether the disease is progressing or not progressing, and whether it is with treatment or without treatment, to see whether the surgical treatment or orthopedic exercises are conservative or non-conservative treatment given to the paralytic or restrictive squint, whether it's effective, it's working or not, or whether the patient's condition is worsening. For the prognostic causes, prognostic purpose, it can be used. So diagnostic and prognostic. Now how the testing is done. Testing distance is 50 centimeter. Explain the procedure to the patient. Patient will require, this test requires red-green glasses. The green glass is placed before the testing eye, so we need 2 glasses, and the glasses which can be switched in the frame. And red glass is the fixating before the fixating eye, and before the testing eye, green glass. So red green goggles are required. Then full refractive correction is given, especially near, obviously near distance ball, near, because it's a near test. Then red light that acts as a fixating light projected on the testing points, and patient is given what? Green light torch projecting the green light. So if the red light is projected on the screen, the patient is through that green light coinciding with that red light, above that red light. So these points are tested, and then it is mapped, points are joined to see whether the muscle is underacting, overacting, and whether this underaction, overaction, it is seen, and this kind of motility, obeying the Sherrington's law of, or Herring's law of, Herring's law, these muscle laws, if it is following or not. Depending upon that, we can decide whether it's restrictive or paralytic squint. So testing distance is done, patience, red green glasses, then projecting light. Now testing points. 9 gauges, inner square is there and outer square is there. You see the videos and then you come here, then you will understand it better. There is inner square, outer square, and there are small squares. Each small square, it corresponds to 5 degrees of angle of deviation. Each line, horizontal or vertical or square, you can say. And there is central fixation point, and after 3 boxes, that is 15 degree, there is a line outline, that is the inner frame at the 15 degree distance, and there are 9 points on the inner square at the 9 positions. So that's the first inner frame and the square. Then there is the outer square frame, and there are 16 points. So 16 plus 9, 25 points to be tested. Now interpretation, how to interpret this chart. So you either there is a paralytic squint or restrictive squint. Paralytic squint means these nerve palsies, and it can be committant or incommittant. Okay, committant means deviation is similar in all cases, and incommittant means deviation is not similar in all cases. So paralytic squint can be incommittant and committant. Incommittant in the early acute onset phase, and in late onset phase it becomes committant. And then restrictive squint means thyroid ophthalmopathy, orbital floor fracture, muscle entrapment, along with that Duane's retraction syndrome, thyroid eye disease, and what else? Brown syndrome. These are the restrictive squint types. So what happens? How to determine whether it's paralytic squint or restrictive squint? In paralytic squint, it will obey the Herring's law of equal innervation and Sherrington's law of reciprocal innervation, and in committant, it doesn't follow that thing. Not always, like often it doesn't follow. So if it is paralytic squint and acute onset, that is incommittant, you will see the contralateral synergist overaction. The smaller field in incommittant paralytic squint, the smaller field, smaller chart belongs to the paralyzed eye, affected eye, and the wider field, it will belong to the eye, and that wider field, the direction, it will show the direction of the action of the overacting contralateral synergist, obeying the Herring's law of equal innervation. What are these laws? You can just Google and you can see the videos are better. You can read, but videos, or if you are just post-graduation, you have completed your post-graduation, my throat is now, I need water. If you have completed your post-graduation, you don't need to go through you don't need to read the books again and again. You can just watch the videos and you know what is standard and what is not standard. So yeah, so that is committant and incommittant. So smaller field, it belongs to the paralyzed eye, affected eye. A wider field belongs to the normal eye, with and direction of the action, the overaction is shown by the contralateral synergist. If it is paralytic squint but committant, both the fields, both the mapping of the Hess chart, it is similar. The boxes are almost similar in size, and committance, the deviation will be seen like almost similar. That's why the similar sized box. So it's because of what? You will see there is smaller field under action of the affected muscle, and under action of the affected muscle, and contracture of the ipsilateral antagonist because of the long-standing paralysis. Then you will see contralateral synergistic overaction and contralateral antagonist underaction because of the inhibitional palsy, because of the same muscle, same side muscle. Contralateral synergist is acting, overacting, because this muscle is not acting properly. It's sending extra innervation, so extra innervation is going to the contralateral synergist, so it's overacting. And as it is overacting, the simultaneous equal intensity negative inhibitory impulses are going to this muscle. This is ipsilateral antagonist and this is contralateral antagonist of this muscle. So this is how the commit and Hess charting is seen in paralytic squint. And when it is restrictive field, it is horizontally compressed and either vertically compressed or horizontally compressed. There can be contralateral synergistic overaction that can be seen. And in Brown syndrome, it is inferior oblique overaction with or without superior oblique overaction. With or without, it's just inferior oblique underaction. Sorry, inferior oblique underaction is seen in Brown syndrome. That chart I'm going to show, and it is like a dog ear filled, like a folded one ear folded like this. So that I'm going to share here. You can go through these things, but if you go through the videos I'm going to share here, you will understand it better. First, I'll just share the link where Hess chart, how it is done, is shown. I think they have used different lights, but standard is red that is projected and green the patient should throw on the screen. So this is the standardization, and green is the testing eye and red is the fixing eye. So this was about the Hess charting. There are certain examples. I'll make part 2 of it. There are certain examples here. You can already go through the examples in the videos. There are so many examples, but there are certain examples here in this book that I'm going to add in this video, or going to make a separate video on it. So this is the first example. Let us not look at this. What is this? So this is the inner square. This is the central fixation point. It's like, it seems normal here almost. Yeah, I think, yeah. So what you'll see, there is lateral rectus action is not here in the right eye. This is the left eye. Here also there is a limitation here, abduction, both eye abduction, and there is overaction of this muscle. So I think it is, yeah, you can see as this muscle is overacting, this medial rectus is overacting, this contralateral synergist is lateral rectus, it's underacting. So this is the muscle that is affected. This left eye lateral rectus is affected because its contralateral synergist is overacting here. This is also limited. This abduction is also limited here. Yeah, it's like spread of the, almost spreading of the committance. It's between acute and late onset. It's just spreading. It's a paralytic squint, left lateral rectus palsy. You understood why it is not here. Also abduction is limited, but you will see the medial rectus overacting here. So its contralateral synergist must be underacting here. So this is the thing. This is also overacting, but this is more overacting. So this is the muscle that is first affected, and there is a spread. There is a process of starting of spreading of the committance here. But first is this. You see which is more underacting, this or this, and which is overacting, this or this. This is overacting. So this is the muscle that is underacting. I hope you understood this. Then sorry. So in this, what we'll see, which is the smaller field? The right eye. This is the right eye. This is the smaller field. So this is the eye that is affected. So what is limited? The abduction is limited here. Abduction is limited. And what is overaction? Overaction is this is the right overacting, right medial rectus is left medial rectus is overacting here. So which must be underacting? This must be underacting. So you will see the left lateral rectus underaction, which right eye lateral rectus palsy. So we are correcting this. It's contralateral synergist overacting, and this is underacting. And we'll see what. Almost both are same. So it seems like it's acute onset because it's a palsy, but acute onset because both boxes are not similar in size. Here you will see almost both boxes are similar in size, so we cannot say that which muscle is, you know, underacting, but you can see this medial rectus is going beyond this frame. This is inner frame, this is outer frame. These are the 9 points on the inner frame, these are the 16 points on, but these points cannot be tested because it's extremely overacting. This is overacting but not that much overacting, so its contralateral synergist is not acting properly in the first place. So this is the right medial rectus, but it's like spread of committance. It's in the process of spread of committance and almost similar size. So it is like long standing right eye lateral rectus palsy underaction. So what we'll see here, I have just to clear the points. See here, it is only the contralateral. Here there is a right lateral rectus palsy, and contralateral left medial rectus is overacting. Okay, everything else seems almost normal, but here you will see this muscle right lateral rectus is underacting. This is the normal field, it's underacting here. And it is overacting, it's going beyond this point. So this is underaction, right lateral rectus underaction. Its contralateral synergist is what? Medial rectus overaction, first thing. Second, you will see the inhibitional palsy of its contralateral antagonist. What is this? This is the lateral rectus, its contralateral antagonist underaction. It is because of the Sherrington's law of reciprocal innervation. It's because this muscle is overacting. So inhibitory impulses are given to this muscle. So this muscle is underacting. And why this is overacting? Because this muscle and this side is affected. Extra nerve impulses are going here to this muscle because it's weak, because this paralysis is there. So this muscle will also get the similar and simultaneous equal innervation, that is Herring's law, and that's why it will overact, but it's underacting, and that's why it's overacting. And as it's overacting, the simultaneous reciprocal innervation will be given here, that is lateral rectus of the other eye, and that is contralateral antagonist of this lateral rectus in the right eye. You will see the ipsilateral antagonist of this muscle. Right lateral rectus ipsilateral antagonist is medial rectus. And why it's overacting? It should stop here, but it's overacting here. Why it's overacting? It's because of the contracture of the ipsilateral antagonist. Contracture of this muscle happens, and that's why it's overacting. So this is how the committance spreads in the late phase of the paralytic squint. So now we'll see here, we'll see almost equal are there. So you'll see 1 2 3 here, 1 2. So this is affected, right lateral rectus, right? Yeah, right lateral rectus is affected first, and then it's like a spread of committance. You can see almost similar. It is given bilateral. Yes, it is affected, but it can be in the process of the spread of committance, and this must be first affected. So another thing is, what is this? What is the smaller one? This is affected eye, and what is overacting? This is overacting. Now this seems like it is totally compressed. It's vertically compressed, horizontally compressed. So what's happening here? Medial rectus is not acting, superior rectus, inferior oblique not acting, inferior rectus not acting, superior oblique also not properly acting. Lateral rectus is almost, yeah, lateral rectus is acting well. So abducens is acting, 6 is acting, but everything else is not very well acting. So what happens? The eye is what? The eye is down. Central fixation is here. The eye is down and out. Yeah, beyond the lateral rectus, beyond this position. So eye is down and out. It is seen in which conditions? It is seen in which condition? Left eye, third nerve palsy, oculomotor nerve palsy, down and out eye. And what is here? It's overaction of the contralateral synergist. So what is this? Which is smaller? This is right eye is affected. And what is underacting here? This is superior oblique that is underacting. So its contralateral synergist is inferior rectus, overacting. Superior oblique underacting, inferior rectus overacting. So what is this? Superior oblique palsy, right fourth nerve palsy. Superior oblique supplied by the trochlear nerve. Now what is this? It is like a spread of committance. This ipsilateral inferior oblique is overacting here. It was not overacting. Here it's overacting. Means there is a contraction happening over here. It is the acute onset. It is the late onset right eye fourth nerve palsy. And then old means like late onset. Not late onset. It's like late phase. So superior oblique palsy or fourth nerve palsy. So ipsilateral contracture, which is not seen here. Contralateral synergist overaction. Here it is seen, here it is seen. In acute stage it is seen, in the late stage it is seen. And what is there? What else is there? Contralateral antagonist. Contralateral and antagonist inhibitional palsy. Contralateral antagonist is what? This is superior rectus. This is this is underacting. So this is the old case of fourth nerve palsy, superior oblique underaction. Paralysis, old case. Now what is this? Which is smaller? Almost both are similar. So again superior oblique underaction, inferior oblique overaction, underaction, overaction, overaction, underaction. Like proper spread of committance. It is like committant or superior oblique palsy. And it is seen in both the conditions. You can see here, here, right? Then here. So it is a bilateral asymmetric, actually almost it is symmetrical, bilateral asymmetric fourth nerve palsy, superior oblique palsy. And it is late onset because you will see the contracture here. Ipsilateral antagonist overaction is seen, so it is a late phase. Here also it is seen. So which is smaller one? This is smaller one. What is affected? Abduction of the left eye is affected. So left lateral rectus is affected. Contralateral synergist overaction, medial rectus, right middle rectus overaction, right lateral rectus palsy, right? Yeah. Left Duane retraction syndrome. You can say, yeah, limited abduction. Fine. You can say it's like lateral rectus palsy or left Duane retraction syndrome also. Then here it's a smaller one, so it is, what is underacting? Inferior, right inferior oblique. This is the right, this is the left. Right inferior oblique is underacting, right? And everything else is almost normal, but here what's overacting? It's contralateral synergist is overacting, so it's acute stage. Because its ipsilateral antagonist is not overacting, so it's like acute, it's still in acute stage. And you will see it's inferior oblique palsy, and everything else is normal. Superior oblique action is also normal, and this is overaction. Okay, so it's like contralateral synergistic action, but here it's not. Either it is acute onset inferior oblique palsy or it is Brown syndrome. In Brown syndrome also, because superior oblique is not overacting. Yeah. either it's inferior oblique palsy, acute onset, or it is a Brown syndrome. In Brown syndrome, there is a dog ear filled, like this. Suppose these are the ears of the dog, okay, and this is a kind of folded ear, like dog ear filled in Brown syndrome. This is the right eye Brown syndrome. Now what else is remaining, which is smaller? This one is smaller and it's like vertically compressed, so it seems like restrictive, and according to Herring's law, overaction of these muscles here and here, contralateral synergistic muscle overaction. But what happens, though there is contralateral overaction muscle, but there is no ipsilateral antagonist muscle overaction, and that's why this is how it differs from the paralytic squint. Because if it was paralytic here, medial rectus paralysis was there here, then there would be overaction of this muscle, right? Overaction of overaction of this muscle because of the contracture, but it is not seen like this. It's like compressive field, horizontally or vertically compressed field means it's a restrictive one. So this is what blowout fracture of the right eye, like restrictive squint. So that was all about the Hess chart. I hope you understood this, but before going through my video, better you watch the videos I have shared, the links of which in the description box. So I hope you have understood the Hess chart well, but to have the thorough understanding, it's like not thorough or thorough, it's thorough understanding, thorough understanding. Yeah, I hope you have understood Hess chart nicely, thoroughly, and I hope it will help you to write the answer of this question if it comes on Hess chart for short, as a short answer question. You'll be able to write it down nicely. I'm going to share the screenshots of it. I'm going to attach to this video. Hope it will help you, but only this video is not sufficient, because you have to see how it's done, how it looks. For that, you see the first video given in the description box, the link of which I am sharing in the description box. You definitely go through that thing, surely you go through that thing. Then second thing, rest two videos I'll share. Yeah, one from Shankar Academy, and then like if you don't have time, first two videos at least you see, you will understand everything. And last two videos, like last 3-4 videos are extra. Like I literally gave 3 hours for Hess chart. And this is what happens when you just there is a gap in your study and practical in your career field. If there is a gap, then again you have to think, and especially when you are making a video. If I was to read only, then it would take only 5 to 10 minutes, but if you want to remember it longer with crystal clear concepts, like nicely understand with different examples, then it definitely takes a lot of effort and time. And I can give it I could give, and still I can give time to study certain things in detail, which I had done, but some things I had forgotten, and there are certain new things which I'm learning from different videos and reading other standard books like Jacobi's, because I didn't read Jacobi's every chapter. Like very few chapters I read during my post-graduation. So I do have time, and I'm going to make the best use of my time of reading these standard books and making nice videos. And I'm going to make them available to you. Also, I'm going to share the index of volume 4 of Albert Jacobi. If you want, you can just wait till tomorrow or the day after tomorrow. I'm going to share the index of Albert Jacobi's, and in every week I think when you have a soft copy, usually it is not accompanied with like Yanov and Albert Jacobi. There is no index of these soft copies there, in the book there is no index. So I'm going to make a index, and then I think it will be helpful for you, and it will save your time, because there are 4 volumes of Jacobi, so it's better to go through the index that I'm going to share here. It will help you, it will save your time. The job of any teacher is to put efforts yourself so much reading standard books and gaining a lot of experience, and shorten the learning time of a student and work as a catalyst. The student doesn't have so much time. You just take the notes from each and every book, read standard books, and integrate all the knowledge, take all the notes and make it available to your student. It will be very helpful to them, rather than just telling them just read this and read that. Put efforts, save their time. As a teacher, it's your responsibility to save their time. So save their time, because you have already gone through those kinds of days where you don't have time to read, so many standard books. So as a teacher, you have a time. You read them, you take the notes of them, and you make them available to the students during their post-graduation, and it will be of immense help to them. It will save their time. The teacher is a catalyst, not an obstacle in students' growth. If that teacher is an obstacle, that person doesn't deserve to be a teacher in anyone's life. That person doesn't deserve to be called as a teacher, because teacher's definition is the teacher is a catalyst. The teacher says, hastens the process of learning and skill gaining, and not the teacher who works as an obstacle is not a teacher, not worthy to be in that position. Bye. Good night, because it's my sleeping time.